case of AIDS was discovered in 1982 in Rakai district, but this disease was not recognized as AIDS until 1985 when prominent Ugandan medical scientists did the first diagnosis. On Friday 1st December 2023, International AIDS Day will be commemorated under the national theme, Ending AIDS by 2030. Keeping communities at the center. The President of the Republic of Uganda, His Excellency Yoweri Kaguta Museveni, will be the chief guest at the national commemorations of World AIDS Day at Chibali Playground in Rakai district.
Okay, a very good evening to you who is watching UBC TV. Thank you for joining me on U Health Chat. My name is Sophie Matovu. Now, tomorrow, on the 1st of December, Uganda will join the rest of the world to commemorate World AIDS Day. And World AIDS Day is going to be commemorated under the global theme, Let Communities Lead. So you'll find that communities living with and affected by HIV continue to be essential for the progress in the HIV response. Our topic today is derived from the national theme that has been chosen for Uganda, and that is Ending AIDS by 2030, Keeping Communities at the Center. In me with studio is Dr. Daniel Byamukama, who is the head of HIV prevention at Uganda AIDS Commission. Doctor, a very good evening to you.
Good evening.
Thank you so much for making time to come through.
You're welcome.
Okay. Now, Doctor, I don't take it for granted that people, when we talk about Uganda AIDS Commission, there is also AIDS Information Center, are able to tell the difference. In about a minute, tell the public, who is Uganda AIDS Commission?
Oh, thank you. Now, that's an important question, because even me, during my work, I find people addressing me as from AIDS Information Center. Or sometimes, actually, they address me as from TASO. But Uganda AIDS Commission, number one, is a government agency which was constituted by an act of parliament in 1992. It is under the office of the president. And it was constituted because from the beginning, from 1986, the HIV response was mainly in the hospital and the Ministry of Health. But it later became clear that to mount a real reasonable response, so many other sectors had to play a part. The religious leaders had to play a part. The media had to play a part. The cultural leaders had to play a part. It was discovered that the determinants of the HIV spread were coming from could be under the control, were under the mandate of various sectors. So we shifted to a multi-sector response. Beyond the health sector, all the other sectors have a role to play. So the Uganda AIDS Commission was constituted or was formed to help coordinate. Because without proper coordination and oversight, the religious leaders can go off and mount their own response and mount their own message. So that we are all mobilized under one message, under one strategic plan, and under one monitoring framework, so that we're speaking the same language. So to help coordinate all the sectors, reminding each sector of their role, holding sectors which are a bit not moving, letting the others down accountable. That is the mandate of the Uganda AIDS Commission. And it was put under the office of the president because from the beginning, His Excellency has always wanted to be directly providing leadership for the HIV response. And as you rightly said, tomorrow he's in Rakai for the World AIDS Day. I mean, World AIDS Day commemoration. And this he has done, I tell you, since 1988, when we celebrated the first World AIDS Day. So it's total commitment and leadership, political leadership at a high level, which has really helped us make achievements that we are proud of. And everywhere we go, if you're from Uganda, we are proud of having been a good example of mounting an effective HIV response.
Okay. So I believe you have a very good database, because there are times that is why we're able to see that the prevalence has gone either high or this is where we stand. What are the statistics of HIV as per today in the country?
Because of HIV treatment, effective HIV treatment, as you're well aware, since around like 2000, we started giving people HIV treatment. And this was greatly increased like after 2004. So every year we increase on the number of people on antiretroviral therapy. So our people living with HIV live longer. So the number of people living with HIV keeps increasing. As I speak now, we estimate we have like 1,480,000 people living with HIV in Uganda. Of those, around 80,000 are children below the age of 15, so that makes 1.4 million, those above 15. So, but on average, when you talk in terms of percentages, what percentage of the population, what proportion of the population has HIV, we're now at 5%. Long ago, like in the early 90s, we're around 18%. So you can see we have really worked hard and come close to 5%. But I must point out that HIV still remains a problem of women. Though we are 5%, if we break it down between man and women, you'll find the prevalence is much higher in women compared to men. So at national level, we find that it's 6.5% among women, and it is 3.6% among men. This is more than double. And I hope as we go along in our conversation, we shall really find out why is it affecting women more. And of course, even then, even if it differs between men and women, we see even geographically, some regions are worse off than others. So if you go to a region like West Nile, you go to a region like Karamoja, the HIV prevalence is low, an average of like 2%. When you go to the eastern regions of Teso, Bukedi, Busoga, the prevalence is average around 3%. But when you come down to Lango, Acholi, Buganda, Ankole, the prevalence, those are the leaders in the country. The prevalence is even above average, even more than Kampala city. It goes up to 7%. Was and 8% in Buganda. So it varies by region, it varies by gender, between man and woman. And if I look at a city like Fort Portal city, it stands out significantly. The HIV prevalence is more than 3 times the average prevalence.
Well, now,
if you go to a district like Mbarara, the rural Mbarara, not Mbarara the city, the HIV prevalence is almost 3 times the national average. The prevalence of rural Mbarara is higher than the prevalence of Kampala, which would be surprising. Everybody would be expecting that the prevalence of HIV is higher in Kampala. But we see in rural Mbarara, the prevalence is high, it's above 14%. We see in Fort Portal city, the prevalence is high, it's above 16%. So, yeah, so we have pockets of high HIV prevalence, but also have pockets, districts like Nabiratuk or Amudat, close to 1%. So I think that is attributable to lifestyle, the lifestyle of the people, cultural issues. So if you look at the eastern side of the country, there are a significant number of highly circumcising cultures. We have discovered, there was research which was done here, which showed that circumcision is protective. Of course, it was dismissed quickly. But we started a circumcision program. And as I talk now, we have done surveys which show that around 57% of adult men in Uganda above 15 are circumcised. So if we have 57% of men now already circumcised, we are able to infer now, we have a big sample to infer who is actually still contracting HIV. So among men, it is very clear that the adolescent men and young men who are not circumcised, and formerly married men, the divorced men, the ones whose wives have abandoned, who are not circumcised, they contribute significantly to the number of new HIV infections. So circumcision is clearly protective. So we would want to call upon our countrymen and women, men, especially young men, get circumcised. The evidence is clear. This is outside research now. This is at population level. We find that the uncircumcised man is left behind. And the uncircumcised man is the one who is now spreading HIV to the young women. So when we quantify the proportion of new HIV infection we find that the young woman between the age of 15 and 29 years is at a great disadvantage.
Oh dear.
So when I come to Kampala, I find that 50% of all new HIV infections in Kampala last year, they were among the young women. The beautiful young women you see walking on the street, the young and vibrant, the one who can even jump a fence.
Yes, why?
So it's multiple factors, of course. It's multiple factors, but I think key to the challenges of women, of course, is that women are disadvantaged in terms of HIV prevention tools. You see, for a man can decide to wear a condom if they want to.
Yeah, true.
A man can decide to circumcise. So there are variable HIV prevention tools. They favor a man. They leave a woman at the mercy of the man. So even if it's a young woman who really has an intention, who really would not want to contract HIV, she's still at the mercy of the man. Is it her boyfriend, is it her husband, to accept and wear the condom? To accept and allow her to wear the female condom. But that's one of the factors. There are no tools under the control of the woman. So she stays at the mercy of the man. So secondly, of course, there are other factors, the social structural factors and the behavior factors. Me and you must agree that the main mode of HIV transmission in Uganda is through sexual activity between men and women. It's the main one. And the second is from mother
to
children. So it's sexual behavior. So a significant number, and we notice this in our data. We monitor that a significant number of girls are initiating sexual activity much earlier now, even boys. But girls have a disadvantage that they engage in sexual activity with much older men.
And for the boys, it's also the other way around.
But we are not seeing a trend. And this, I must let it out to the mothers outside there. There are we are not seeing a trend in new HIV infections among boys, which points that the sugar mommy syndrome
has reduced.
The sugar mommy. You know, we have always been worried about the sugar daddy syndrome. The girls in Kampala are highly affected because of the sugar daddy syndrome. The rich old men who have the jobs the young women need are taking advantage of the young girls. The rich old men who have the money the young girls don't have are taking advantage of the girls. You know, promise of giving jobs has made so many girls contract HIV.
And
we
gifts.
know that. And gifts. So, but we see the trend is catching up with the boys. A significant number of rich women in Kampala now engage in sugar mommy business, and a significant number of boys. So we're seeing an increase in the new HIV infections among adolescent young boys that are of concern, and it points that the sugar mommy syndrome is also taking up root in our society. So you call upon the parents. Of course, it all comes down to parenting. So why are young people now engaging in sexual activity much earlier? Significant proportion. By the time they turn 15, they're already experts in sexual activity.
Oh dear.
And we monitor. So those who have already started engaging in sexual activity, how many of them have a faithful partner? Since you are not married, it's very difficult for young people to have a faithful partner. So those who have started engaging in sexual activity, we see that they engage in multiple sexual partnerships, and they don't use condoms as it should be. So it goes back to the parents, that the parents have become so busy looking for money. The parents have become so busy socializing, and they have forgotten to take care of their child. But would want to call upon the parents. Don't negate your responsibility of raising the children, because the time of adolescence is a challenging time. It's a time of confusion, it's a time of peer pressure, where people influence your child to try on new things that are out of fashion. But I think with communication and correction, and it's easy. because you have been as a parent through these phases, you know how you survived them. So it's so easy to take off time and listen to your child and provide them with guidance. One of the other factors that we think explains the so many young people contracting HIV is information. We do these surveys and we find that especially young people are not knowledgeable. They still have some myths in their heads, which means that the campaign, so when we were young for us, the campaign was very vibrant. The religious leaders talked to us, the political leaders talked to us, but I think this message has died out. Now, there is a whole generation of young people who have matured now, who did not benefit from that aggressive campaign.
Yeah, true.
So they appear to be ignorant, and we see it still contributing to the continued spread of HIV to babies. We have what it takes to make sure there's no child born with HIV.
True.
But when we do our surveys, we find that some mothers who are so ignorant of what needs to be done to make sure they deliver a healthy baby. So we appreciate the media. So through the media, this message gets out. It's an opportunity to come in and talk to the people that it is possible to deliver a child who is not having HIV. But if you engage with health workers, and that is part of our national goals, to make sure there's no more children born with HIV, because it can be done. Even the adults, because as part of the theme, ending AIDS by 2030, one of our goals is to make sure there's no more Ugandan contracting HIV. That is achievable. The other one is to make sure there's no Ugandan dying of AIDS-related illness. That is achievable. But unfortunately, last year, 17,000 died of AIDS.
Oh dear.
Which is a shame, because we have treatment now, effective treatment. So when you started the treatment in 2004, people were swallowing handfuls of pills.
Of pills, yeah.
Now it's just one pill, once a day. And people are still really shying away, not coming for this treatment, and which is very painful. So we believe we have effective treatment. There's no Ugandan who should be dying of AIDS-related illness, but 17,000 died last year. So we hope by the time we get to 2030, we will have convinced all of them to come for this treatment. There is no Ugandan who should be dying of AIDS illness now.
Now I'd like us to get to the global theme.
Yes.
Why was it tailored that way? Is it because they realized that the communities are not fully engaged and involved? Let communities lead. Why are they pushing for the communities? Because I believe they have always been engaged and have been supportive in the fight against HIV.
So let communities lead, that is a global theme.
Yes.
But you'll notice that the Uganda theme has modified that theme.
Sure.
Let them continue to lead, let them at the center. So the Uganda theme recognizes that for us, we're already advanced in that area, engaging communities in the HIV response. And I will tell you why communities are important for the HIV response. When you draw back, you'll notice that our HIV response started around 1986, or thereafter. But something else happened that you must be aware of. We formed an association called TASO, the AIDS Support Organization. And it is still alive and still vibrant now. This was an association formed by people affected who have lost loved ones due to HIV. Some of them were living with HIV. This is a community of people living with HIV, affected with HIV. And I would want to tell you that TASO has provided leadership since that time, and it
until today.
So for us in Uganda, we have known since time of the response that we need communities, because TASO and other community organizations and other community groups which have participated in the HIV response, they have come up with innovations. Some of the innovations that we have adopted as standard practice. Recently, we launched a campaign, a national campaign, reinvigorating our drive to end AIDS in children. It's called an Alliance to End Pediatric AIDS by 2030. And at that alliance, at that launch, we asked young people living with HIV to speak. It is not us who gave the speeches. It is the community members. So there was a young mother who has had just one baby. So she stood up to speak. A young mother living with HIV. She has gone through the hospital or health facility, health system. She managed to deliver a child without HIV. But she stood up and gave a speech. She's not a doctor. She's not trained in public health. She gave a speech that details the challenges of our health system, of the whole pathway where other mothers have managed to fail. We are so happy with her speech. But from her speech, you could see that the communities understand where the problems lie. She told us, why haven't you integrated the antenatal care with HIV treatment? Moving from antenatal clinic to look for treatment, it was a challenge. I'm exposed to stigma. I almost dropped off. Now, she pointed us to where several of the women drop off. She told us the stories of gender-based violence that she has suffered as a positive woman with brothers-in-laws and sisters-in-laws stigmatizing. Now, she really touched the things we need to address, which are making several women drop off treatment. Because from our studies, we have known that a big number of women who are HIV positive, almost all of them, we start them on treatment. Because everybody comes for antenatal almost, and we test them for HIV. Those who find HIV positive, we start them on treatment. But a certain number drop off treatment. The issues that really explain why that number drops off treatment came out in this young woman's speech, which shows you that the communities know. Me as a doctor, I would not have sat behind there
and thought
and
about
imagined this. And she was even coming up with solutions. What do we need to do? Find a way of integrating the antenatal clinic with HIV treatment so that mothers don't have to move from the antenatal clinic and start running around looking for the ARV clinic. Coming up with solutions. So, but now the global theme has said, if we are going to end the epidemic of AIDS, let's listen to the communities. Because we notice now almost all our progress has reached stagnation stage. We have been reducing the number of new HIV infections continuously, but we are almost flattening off. Now, the remaining populations which have not yet been reached, those who have been left behind, they need a different approach of addressing their need. And that is by engaging them, allowing them to tell us, and you saw it during COVID-19 lockdown, the communities came up and mobilized themselves on how to help. I remember the communities of sex workers in Kampala gave me a call. They said, doctor, for us we are finished now. Because now that they have crossed the streets, our source of income is we are getting finished. But they mobilized themselves. We don't have means of transport to go and pick our drugs from the antiretroviral clinics. But we listened to them, and they proposed ways of how we can help them deliver drugs
from point A to point B.
A. They know each other. The sex workers, they know each other. How we can help them get food. Because their source of livelihood had been totally closed off. And you will discover that communities know how to solve their problems.
True.
If we had stayed there to guess, as health workers, I think we would have gotten wrong. So what this theme is saying is that the remaining populations, which are still left behind, let them show you the way to help them. Wow. Let them even participate in offering the solutions. But fortunately, as I've said, for us, the Uganda theme, you know, as you're aware, our HIV response in Uganda is the oldest. It's actually the oldest. So most other responses were modeled based on our response. So for us, we already knew the importance of engaging communities. And if you look at our structures, our HIV coordination structures, is it the National HIV Prevention Steering Committee? Communities are there. Communities, is it young people? They are represented there. Is it people with disabilities? They are represented there. Is it people living with HIV? They are represented there. And even all the processes, are we developing a global fund grant application, who sits at the table? It is the communities. It's the communities of sex workers. I have been to meetings with sex workers, and anybody who meets a sex worker may think they are dealing with stupid people. They're not stupid. they think they advance brilliant ideas of how they can be helped overcome the challenge of HIV. We sit and so the most affected communities, we know them, and we have tried in our national response to bring them to the table. Is it young women, adolescent girls and young women? We have them. In our planning meetings, we have given them audience, though I may not say that we are at 100%. There's still work to be done for the communities. Number one, that for communities, if you look at the way they work, they find money. You don't know how they raise this money. And we thank God for the communities, for civil society, for community-based organization. They meet friends when they travel, and they spend sleepless nights writing grant proposals, and they bring some resources that support the national HIV response. They innovate on ways of solving their problems in the communities that for a health worker sitting on the other side, you not have thought of. So we are proud communities. The challenge, I think for Uganda, what we still need to do is to secure their source of funding.
Yeah, true. Funding
that is from donors is on and off. You win a grant, 1 year, it expires, and then you're back to zero. They need acknowledgement of their support, because you will go and you find that some public officials do not recognize and even are proud and appreciate the contribution of this community-led organization. And I think this theme comes at the right time. I think it's a call on all our leaders. And I'm very sure when the president addresses people in Lakai tomorrow, because it's a theme, he must talk about it. He must applaud. I know he's prepared to appreciate communities, their innovations, and their efforts in delivering services, most especially to the hard-to-reach communities. Me and you know that the hospitals are placed conveniently. So in hard-to-reach places, the communities themselves find a way of innovating, of raising resources to make sure the services reach them.
Yeah.
And some of the innovations which were started by communities have been standardized. They're standard national practice. So we appreciate communities, and we believe with this theme, the theme calls on us, make the communities, let them show you the way. Let the community of sex workers show you how to help them, and then the problem of HIV among sex workers. And I totally agree with the theme, because I've sat with sex workers in meetings. They're not stupid people. They give brilliant ideas. Yes.
Then there are certain times, yes, we all know the first case of HIV was identified in Rakai.
Yeah.
For the years, of course, we've been having the commemoration happening in different places. Why Rakai this time around?
Yeah.
Why did it turn out that way?
So the first case of HIV in Uganda was identified in Rakai. So we want to, it's a point of reflection, to go back and reflect, where did we start from? In the 1986, in the 80s, it was a very painful sight. Right now, most of our brothers and sisters who are living with HIV are on treatment. They are healthy, looking normal. And because of that, it has created some complacency. If you notice, in the 1990s, early 1990s, the HIV prevalence was as high as 18%. Without antiretroviral therapy, just by drumming and talking, we reduced the HIV prevalence. By the year we got to 2002, it had reduced to 6.5%, from 18 to 6.5%. But since we introduced ARV, since 2002, this is 20 years later, we have only reduced the prevalence to 5% by 1.5. So the introduction of ARVs, which is a good story, has created some laziness, some complacency. I've even heard that young women say they don't fear HIV. They fear pregnancy, they don't care about HIV.
Very true, they say that.
So, but we would want to go back to Rakai and reflect and re-strategize. It's a moment of reflection, of retelling the story, reminding and reinvigorating ourselves that we must not get complacent, we must move all the way to the end, and it is possible. If when the president launched the Presidential Fast Track Initiative to end AIDS by 2020, the president is very careful. He asks very hard questions. So, but the technical people convinced him, and he was convinced. You don't easily move him around. That we actually have the tools to end AIDS by 2030. One of the most effective tools that we have, which is a good tool, is HIV treatment. So when people who are HIV infected are started on treatment, which I've told you now is just 1 pill a day.
As opposed to a handful
As
before.
opposed to a handful. If they are taking it very well, it is good for their health. They will stay healthy. They will go to work. They are our bosses in offices. But it is good for the community is that a person who is taking their treatment well does not transmit HIV. So imagine if we are going to put every person living with HIV on treatment. Wouldn't we have, if we can afford to identify everybody who has HIV in this country, we know through scientific methods that we have close to 1.5, 1.48, but we have not reached all of them. But through research and sampling methods, we know that we have around 1,480,000. But of those, we have reached like only 1.3 with HIV testing. The other, around close to 200, we have not reached them. And they are scared of coming for HIV testing because they know their brother or their auntie, if they test and they are positive, somebody is going to minimize them. Somebody is going to treat them as a lesser person, which we call stigma.
Might end even the relationship.
Yes, of course. So the story I've talked about of the young woman who gave a moving speech, she told stories of harassment by family members. She's an educated, brilliant young woman, but the family took her as a lesser person. And she ended up abandoning the marriage, and now she's a single mother because she was getting harassed by the family. By the mere fact that, and she's public because she's vocal. The family to which she was married harassed her around and that kind of thing. But that has a price. That problem we call stigma.
Yeah, sure.
Because when we started the response, you remember Fire Bongore Taya.
Yes, I do.
Came out and warned us that today it's me, tomorrow it's tomorrow it's somebody else. The people I would want to tell you, the people who were laughing at people who had HIV in the 1990s, some of them have HIV now. Some of them died. I am saying that as a warning to everybody there who finds pleasure in stigmatizing others. Whether it is TB, whether it's a dangerous habit.
Yeah, true.
The people who are stigmatizing the people who had developed COVID, I don't know whether there's anybody who has not developed COVID now. But when COVID started, people had gotten into the habit. Some people who recovered and went back to their communities are almost stoned.
True.
So stigma is a dangerous vice. It's a dangerous habit. It is costing us. The close to 200,000 people who are not coming for HIV testing, or those we have tested and not coming for the convenient HIV treatment, it's because, mainly because of stigma. Because they fear. Because, you know, you can imagine if you're at home and you have one of the relatives who is HIV positive, when it comes to a party, who is going to work at the high table, the one who is HIV positive, they will most likely say, no, not that one. Who is going to represent us at the family meeting, the positive one, they are most likely. So that is stigma and discrimination. But we are committed to convince fellow Ugandans that if we do not stop stigma, we may default on our commitment to end AIDS as a public health by 2030. If we stop stigma and decide as a community to to work together, to connive, and stop stigma, we shall allow our brothers and sisters who already have HIV to move freely, to take the medication as the doctor prescribes. They will live normal, respected lives, but it is good for us. They will no longer transmit HIV.
Now, Doctor, I really see you hold a very big position, because when you talk about you're the head HIV prevention. Now, tomorrow, we get down to commemorate the day as a country. What are the new strategies in place that you have, especially for the young people where the infection rate is a bit high?
Thank you. Now, the first one I've told you at the beginning is to make sure all our brothers and sisters who are HIV positive are taking their medication. It is good for them, it's good for the community.
True.
Number two, I have talked about the importance of circumcision. I would want to encourage all young men there,
to get circumcised.
whether you're a Muslim or non-Muslim, go and circumcise. It has nothing. 57% of Ugandans are already circumcised, including the elders in the church. So if you are there still feeling you are more religious, you are more Christian, circumcision is for circumcision for Muslims, even the elders in your church are circumcised. I want you to get out of that chair. If you're still a young person, it's a must. It is clear that the men who are still contracting HIV are mainly the uncircumcised men. Those are two already. Now, when it comes to the young women, we have discovered that one of the best tools to keep a young woman alive and powerful is by keeping them in school. The data is unmistakable. The more the girl stays in school, the less likely. So if we look at those who dropped up at P7 and we compare them with those who dropped up at senior 4, the number of those who are contracting HIV are higher in the former, in those who dropped up at P7. Even when you compare with those who dropped up at senior 6, the number keeps reducing. Keeping a girl at school up to completion is a miracle, it's a blessing. You've done a good thing. So we would want to encourage parents and even community leaders to come up with innovations, even to enforce government programs. There is universal secondary education, the universal primary education, to make sure the girls stay in school. Anything that stands in the way, is it sending away girls from school because the uniform is torn or something? I think the RDCs and leaders should not condemn that, should not condone that. Nothing should stand in the way of a girl to complete school, stay in school. That is a key tool for us. I have talked about the importance of parenting. We see the morals eroding. Young people are starting to engage in sexual activity early. We want to see young people educated. And unfortunately, when we don't feed young people with accurate information, there are so many redundant people who are in the habit of creating myths and fake stories, and they propagate them through social media, through tales to fellow friends, and you find a young man or a young girl who believes that when they engage in sexual activity while standing, they will not get pregnant. And somebody created that story and told it. So we must continue to give young people with information. We notice that most of our young people are contracting HIV out of lack of information or out of information. So educating the people remains our key part of the program. But as I said earlier, it is dying out. So, but would want, since we have just 7 years to a historical day of ending AIDS as a public health threat, would want our leaders, like the leaders who are there when for us were young, to get back to educating the people. The president did this by writing. He developed a message handbook to help leaders talk to the people. He even produced a handbook that we have been sharing. So we would want the church leaders to go back to talking to the people, because HIV is still real.
True.
Otherwise, yeah. So we have come up, I talked about the challenge of women being disadvantaged in terms of the available tools for HIV prevention. But now research has produced 2 new products. One of them is going to be available, it's already available in the country. It's called a vaginal ring. So you have a ring which you insert in your private parts. It stays there for 1 month. You don't need even to tell your husband that you have it. You don't even need to tell your wife. Because I've heard of women who go for family planning injection, when they come back home and tell their husband, they box them.
Yeah, true.
They beat them. I have heard of women, I have seen women when I was still a practicing physician, clinician, who came back to me to help them remove the implants. The implants, because their husband touched and felt something abnormal, said, go and remove them. And you're like, can you help me bring me your husband? And I talked to him, just out of the pressure of maybe being a man. So we know that the available prevention tools, if we look at an example of a condom, it's still very difficult for a young Ugandan woman to go and procure a condom and keep it in your handbag. Anybody who sees it, they will gossip about you in the whole village. They will brand you promiscuous, not responsible. So that is challenging. The other option we have is what we call pre-exposure prophylaxis. So before you are infected with HIV, you can come to us. We shall give you medication, which you must take very well if you consider yourself at high risk of contracting HIV. So if you have a husband who is always infecting with gonorrhea, it's not a matter of how soon. It's a matter of how soon he's going to infect you with. Because the way they contract gonorrhea is the same way they contract HIV. If you have a husband who is busy fathering children in the whole village, it will be soon. He will come, he will get something very soon. So if you came to hospital and told the doctor that this is how I live, or if you're a husband and you know your wife is a sex worker, you come to hospital and say, my wife is a sex worker. Can you do something for me to make sure I don't contract HIV? We can give you medication. It's called pre-exposure prophylaxis. You will take it if your partner develops HIV, she will not transmit it to you. Now, the available modes of pre-exposure prophylaxis that we currently have are pills. But me and you know that it's very difficult to take pills. So even when you have cough and you come to hospital and they give you amoxicillin, it's very difficult.
Of completing
it is challenging.
Yeah.
So that's what we have observed with the pre-exposure. But now, it is even worse for a woman. A young woman who thinks her husband engages in risky sex activity, who comes to hospital and you give her that pill, I'm telling you she's going to get boxed. She's going to be branded promiscuous. She cannot keep it. So we have come up with 2 new tools which we think are convenient for women, will help bridge the prevention gap. The woman now remains disadvantaged, but these tools will be under the control of the woman. The first one is the vaginal ring I've talked about. That one we already have in the country, and very soon it will be scaled up, including to hospitals and health centers. The second one is the injectable ARV. The research which has shown that you can get 1 injection every 2 months. Yes, 1 injection every 2 months, and we believe this is very convenient for a woman. Just like the family planning injection, you don't need to tell your husband, because some husbands we have discovered, they like opposing just for the sake of opposing. So if you think you live a risky lifestyle, and when you come to hospital, the health worker will tell you that you need this injection. But I've given you a pointer. If your husband is always infecting you with gonorrhea, it's a matter of how soon is he going to infect you with HIV. So we shall be giving you 1 injection every 2 months. It's just small, 3 milliliters in the buttocks. And you go back home without announcing, and you come back after 2 months. We believe that is in the control of a woman. So the other idea of fighting with men who don't want to wear condoms, it's okay. You are covered. If your husband or your boyfriend does not wear a condom, you are covered. You will no longer be at the mercy of your husband, of your boyfriend. So we believe, but that, as a challenge, it has not yet secured approval of the National Drug Authority, but we are hopeful that by the end of this year, the National Drug Authority will have given us this pill, that approval, and the young women are already aware. No research gets disseminated and people are reading. And for us at the Uganda AIDS Commission, we are under great pressure from young women. Everywhere I go, the young women ask me, where is the injection? Where is my injection?
When are we starting?
When are we starting? So I am calling upon our stakeholders. The pressure is high, and really as the head HIV prevention, I think this is time for me now to meet the needs of the women. Let's have this injectable so that will bridge the prevention gap that is disadvantaging the women. They can also have something that is under their control. So you can see those are 2, 3, 4. So apart from the condom, the ARV, of course the other one is ending mother-to-child transmission. So a significant number of new HIV infections last year were among children born to mothers with HIV. So last year we had close to 52,000 new HIV infections. Of those, close to 6,000 were children. As I said, there is no reason why we should not be having zero. But some of the mothers have challenges of violence, challenges, no transport to go back to get the medication, that kind of challenges. But we have launched a campaign to make sure we innovatively solve the challenges most of the mothers who have been left behind, to make sure within a short time there is no more children born with HIV. So there is mother-to-child transmission. It involves coming to antenatal, and once you come to antenatal, come at the earliest time possible. The doctor or the midwife will teach you what you need to do to make sure you give birth to a healthy baby. Everybody who has given birth to a sickly baby, because the baby born with HIV is a sickly baby. Because if you give birth to a normal healthy baby, even that one disturbs you going to hospital all the time, flu, cough, malaria. So imagine giving birth to an HIV positive baby whose immunity is so low. The pain is worse, and there is no child who deserves that kind of pain. And even the pain is there for you, the mother, because you have to go to hospital all the time.
All the time.
So we would want to work with the mothers wherever you are to help you deliver healthy babies. It is convenient for you as a mother, but it's also convenient for the child that they don't have to grow up in pain. They live a normal health life, and it's doable because we have it, what it takes
to take care of this,
to make sure every
babies.
mother delivers a healthy baby who is not HIV infected.
Okay. Well, doctor, it's 5 minutes at the top of the hour. I would like to say thank you so much for the talk and for educating us, but it feels, I can see the energy, I can see the direction that the country is taking, and I believe that come 2030, it will be a different story altogether. Well, that is all we had for you tonight, me and Dr. Daniel, as we've talked about a topic of discussion, which is the theme of ending AIDS by 2030, and then the communities are at the center of it all. Well, at this particular point, I would like to leave you, and Mark Arnold Wadulo will be coming your way shortly with the 10 o'clock news. Good night from me and from Dr. Byamukama.
Uganda, the first case of AIDS was discovered in 1982 in Rakai district. But this disease was not recognized as AIDS until 1985 when prominent Ugandan medical scientists did